Good morning, everyone. I'm FA, if you guys should already know me. I'm a PGY3. Today's small talk will be on Priapism. Uh, so we're starting with another interesting episode of Sex and the City. This is supposed to be the intro of it, but the video is not working. So just imagine, okay? So the name of this episode is What Goes Up Must Come Down. And it's a small talk on the management of ischemic priapism in the acute setting. So the episode opens with Carrie thinking to herself, I couldn't help but wonder, when does it stop being romantic and start becoming a medical emergency? So what is priapism? By definition, it is the prolonged, persistent pathologic erection of the penis lasting greater than 4 hours in the absence of sexual desire, and it's not relieved by ejaculation. There are three general classifications of priapism: high flow, which is non-ischemic; low flow, which is ischemic; and stuttering or recurrent. The focus of this presentation will be on ischemic priapism, not only because it makes up a majority of the presentations of priapism in the ED, but because it is an actual emergency of life or limb. Prolonged erection can cause penile tissue damage and erectile dysfunction if it continues longer than 4 hours. And contrary to non-ischemic or stuttering priapism, it's something that it is rarely seen in the ED, but it is obviously an emergency. It can affect individuals of all age groups. The peaks are observed between 5 and 10 years and 20 to 50 years of age. So this is a cross-section of the penis. As you can see, the corpora cavernosa run along the dorsal aspect of the penis. Inside the cavernosa are venous sinusoids that fill with blood during an erection. And the ventral side contains the corpus spongiosum, which houses the urethra. So when flaccid, blood will flow through the cavernous artery into the cavernosa, and it's balanced by blood flowing out of the cavernosa into venules that coalesce in the deep dorsal vein. When stimulated, there's a local increase in the release of nitric oxide by the parasympathetic system. And this causes a downstream effect of smooth muscle relaxation. This allows for a dramatic flow of arterial blood into the cavernosa, causing the physical manifestation of an erection. So I mentioned previously that there are three main types of priapism. High flow is typically due to penile or perineal blunt trauma like straddle injuries, and they cause increased arterial flow to the penis with sufficient venous outflow. And it typically presents as partial tumescent, so it's not like a fully rigid penile presentation. Usually no treatment is necessary, and it's not an emergent condition. It can be managed as an outpatient, and the prognosis is typically good. And often it resolves spontaneously. Low flow priapism or ischemic priapism is an emergency, and it's caused by decreased venous outflow. And so there's decreased venous outflow caused by increased cavernosal pressure. So as the arterial flow increases, it causes pressure on the venous sinusoids, which decrease outflow. This can result, like I said before, in necrosis and fibrosis and permanent erectile dysfunction. So how do we determine the difference between ischemic versus non-ischemic priapism in the acute setting? That's the point of this talk. And obviously you want to do a thorough physical exam of the penis, the testicles, the perineum, the abdomen. That's all important. But non-ischemic versus ischemic priapism cannot be differentiated by clinical exam alone. Get a good history, ask about previous episodes of priapism, ask about duration of the erection, current medications that the patient is taking, past medical history of sickle cell disease or other hemoglobinopathies, as well as trauma. The Urologic Clinics of North America published a guide to aid clinicians in diagnosing ischemic versus non-ischemic priapism. So this table highlights typical findings in ischemic versus non-ischemic. The red box shows the most important part of the diagnosis, which is the penile blood gas. So low PO2 and high CO2 is commonly seen in ischemic versus non-ischemic priapism. And once you do obtain your blood gas, you want to basically evaluate it for a PO2 that's less than 30 or CO2 that's greater than 60, as well as a pH that's less than 7.25. This is diagnostic for ischemic priapism. So what are some causes of ischemic priapism? Erectile dysfunction drugs, psych medications, again, sickle cell disease, which is common in our population, recreational drug use like cocaine, as well as recreational intracavernosal drug use. You might come across a patient that's actually injecting drugs into their penis recreationally, malignancy, as well as neurogenic causes. When divided by etiology, the reported frequency of these etiologies do vary amongst different studies, but I mostly found information that showed that recent studies do report that erectile dysfunction drugs are the leading cause of ischemic priapism in the acute setting. So what is the utility of ultrasound Doppler? I found a lot of conflicting information as to whether or not we should be using ultrasound Doppler in the ED. Urology may go for the ultrasound in the acute setting, in the emergency department. It's not advised to delay treatment by doing ultrasound Doppler. You can aspirate penile blood and send it as a blood gas, and that is the more accurate and appropriate use of or way to diagnose ischemic versus non-ischemic priapism in the ED. So not ultrasound, but aspiration and intracavernosal injection is really the way to treat this in the emergency department. So what do we need? We're going to gather our supplies. You're going to need chlorhexidine. Obviously, you want to try to do this under as clean and sterile as a environment as you can. You'll need a 25 to 27 gauge needle and a 5 cc syringe in order to do your penile block, which I'll talk about. You'll need an 18 gauge needle and a 20 cc syringe for your aspiration and irrigation of during the procedure, as well as phenylephrine, which you'll do after aspirating and irrigating, and your blood gas materials. So before you do this, you want to talk to your patient. You want to talk them through the procedure. This is obviously can be a traumatizing experience. So be kind. You want to give pain medication. Again, this is something that's very painful. You can try things like Toradol. You can do Percocet. Just try to get the patient as comfortable as possible. Consider light sedation like Versed, ketamine, something to kind of make them a little bit less anxious. The management of priapism in the ED is focused on two main approaches: aspiration plus or minus saline irrigation, and the injection of phenylephrine. So there is a stepwise approach. You want to begin with your penile block. The penile block is typically done through like the dorsal aspect. So you want to prep the skin at the base of the penis. If you look at the base of the penis as a clock, you'll be where you'll be injecting is 10 o'clock and 2 o'clock. You will inject about 1 to 2 milliliters of bupivacaine. I would typically do bupivacaine because it's long lasting. Remember to aspirate first and then inject 1 to 2 milliliters and repeat on the other side. You can also try the penile ring block, which is another approach right on the bottom. This requires you to redirect the needle caudally and then advance to the superficial fascia. Aspirate and then inject again 1 to 2 milliliters as you withdraw. This will also anesthetize the ventral aspect of the penis. So once you've done your penile block, you can now move on to aspiration. This is when you'll need about a 19 to 20, typically an 18 gauge needle is used to inject into the dorsal aspect. If you focus on the dorsal aspect, you will not injure the urethra on the ventral aspect of the penis. Once you've aspirated, send a blood gas sample, which will help you clinch the diagnosis of ischemic versus non-ischemic priapism. Then you can move on to irrigation. Typically, aspiration and irrigation you can do back and forth until you've had a degree of detumescence. Once you've done that, you can finally inject phenylephrine intracavernosally. So phenylephrine is most commonly used due to its efficacy and limited systemic effects. You can administer about 200 to 500 micrograms every 3 to 5 minutes, up to a maximum of 1 milligram until detumescence is achieved. You can consider placing the patient on a cardiac monitor because you are giving a cardiac a medication that does affect the hemodynamics of the patient. Epinephrine can also be used. You can dose 100 micrograms and dilute it in about 1 milliliter of normal saline, but there are potential side effects like hypertension and dysrhythmias. And when detumescence is finally achieved, you can place an elastic bandage around the penis and send them for urology follow-up. So I do have a video.
Position the patient. Have them lying flat comfortably on the cardiac monitor. Clean the penis with chlorhexidine and apply sterile drips. Draw 1% lidocaine and infiltrate 1 to 2 cc's at the 10 and 2 o'clock positions at the base of the penis for your dorsal penile block. Alternatively, you may perform a ring block. This is not demonstrated in this video, given the limitations of the model. Parenteral analgesia can also be given. Attach your 18 gauge by 1 inch needle to a 20 cc syringe and access the corpus cavernosa at the 10 and 2 o'clock positions mid-shaft. Aspirate as you enter the skin and enter about 1 to 2 centimeters. When blood returns, continue milking from the distal glands. Blood that is aspirated may be sent for analysis with venous blood gas testing. If detumescence is still not achieved or there is minimal blood return, you may irrigate and aspirate with 10 to 20 cc's of cold, sterile saline. After irrigation and aspiration, instill 500 micrograms of phenylephrine every 5 minutes, up to 2 doses. After detumescence, wrap the penis in a compressive bandage.
So what are some non-invasive ways to manage priapism? Some people can consider giving oral medications like pseudoephedrine or terbutaline, physical measures like cold packing or exercising, or even having the patient ejaculate. You can try hydration and analgesics in patients with sickle cell disease, but these are all considered mild to moderately less efficacious in this situation. The standard of care is aspiration and injection with typically phenylephrine. So this is just a nice slide that I found that kind of gives you a stepwise visualization of how to approach priapism in the ED. So you can start, I would typically skip initial conservative measures. I would go straight to my dorsal penile block and then aspirate, send the sample, do the cavernosa irrigation with sterile saline, and then continue on to injecting with phenylephrine. This is considered first line again. And ultimately, if you are having any type of complication, which we'll talk about that in the next slide, like a hematoma, or you're aspirating and you're irrigating and then you've injected and you're still not having detumescence, that's when you have to start thinking about calling urology. Okay. So again, when to call urology. So if you have, like I said, unresolved tumescence after aspiration, irrigation, and injection, or if there are complications like hematoma or even infection, you want to call your consultants right away. So I did find an article, kind of like New Frontier, basically, that discusses ketamine use in the setting of priapism in pediatric patients. So it discussed the prospect of ketamine use in this situation. A retrospective review of pediatric emergency encounters for priapism over a 7-year course at a single academic institution was performed. And what they did was that they showed, they did procedural sedation on patients given by PEM attendings with IV ketamine 0.5 mg per kg per dose. And it was administered in the setting of just trying to sedate the patient. If detumescence occurred following ketamine administration, then they would move on to the penile block and just observe the patient in the ED. And if there wasn't detumescence after giving ketamine, then they moved on to the actual corporal irrigation and aspiration part of the stepwise approach performed under sedation. It showed that 4 patients met the inclusion criteria. So there were 3 or 4 patients who did have sickle cell disease. And the 4th patient, they attributed their priapism to risperidone use. And all 4 patients ranged from about 12 to 17 years old. And they also had history of prior priapism in the past. So 3 patients were shown to have responded to ketamine use and did achieve detumescence without any corporal irrigation or aspiration or injection. And there were also no immediate reoccurrences of priapism in these patients. Case 4, which is the highlighted red case, was a patient with sickle cell disease that had had priapism for greater than 14 hours that did require corporal irrigation as well as phenylephrine injection for detumescence after ketamine administration. So this case, although very small n size, it's a very small case, it did demonstrate that there is some success with less invasive management of like corporal aspiration and irrigation in the pediatric population for ischemic priapism. This may serve as maybe an early indication that there can be some non-invasive steps in the management algorithm of detumescence and ischemic priapism, but of course, more I think research needs to be done around this. So that's the end of my talk. These are my references and